Welcome to the session. Um, we're in the session for issues on child and family health economics, and we have a very interesting set of 4 different presentations listed today. Just before we start with the session, I'd just like to inform everyone that each of the presenters will be given 8 minutes to present. So we will be going through all the presentations first. If you have any questions or comments, please feel free to type in the chat box, and we'll take them up at the end of all the presentations. And then if you also want to connect with the presenters later on, you can do that individually. So questions, the floor will be open for questions at the end of the last presentation, but you are most welcome to type in your questions or comments in the chat box. And so before we start, I'll ask each presenter to introduce themselves before the presentation. So starting with our first presenter, Nadeem Ahmed. Nadeem, can you please introduce yourself briefly and also start with your presentation?
So hello, welcome you all again. I'm Nadeem Ahmed, PhD scholar at Jawaharlal Nehru University, Delhi. I'm working on health and household welfare, health economics basically. Okay, thank you.
Nadeem, please start your presentation.
Okay, so the title of this paper is Catastrophic Health Expenditure, Poverty and Child Educational Outcome. Okay, so in this 8-minute presentation, I will focus more on issues that we are analyzing in this paper and its empirical approaches, so that we can get some useful suggestion to improve our work. Okay, and at the end, I will show some findings of this paper. Okay, so health shock or the ill health is among the most costly and unpredictable cause to affect the household welfare, especially in low and middle income countries. Okay, so health shock through the health related expenses impose the very high cost, direct medical cost like hospitalization, medical medicines, tests, etc. And it also impose indirect medical cost like the transportation, patient care, okay, and other things. And in addition to this financial burden, it imposes very high indirect cost. Okay, it will lead to reduce the capacity to work or the productivity loss, okay, lost earnings, and then consequently the consumption. In addition to these two direct or indirect costs, it also creates the difficulties paying for household amenities, including the nutritious food, utilities, and most importantly, expenditure on child education. Okay, so this may have destructive implication also for investment in human capital, which make household vulnerable for further economic shock, okay, through the debt, through the making unaffordable healthcare services. Okay, so it leads, possibility leads intergenerational transmission of poverty, poor health, and inequality. Okay, so it means that health shock may be even more costly in terms of household welfare if their consequences are transmitted into the next generation. Okay, so the parent health shock can reduce the children's time for education and play and increase the probability being sent to work. So parent health shock can affect the child education in many ways, through the income channel, through the input time inputs. For example, children education could be prevented because household can no longer afford to pay for it, or children has less time to study as they need to take care of their ill parents. Okay, or maybe because of reduction in the quantity and or quality of parents time inputs into the child or child education especially. Okay, and it may also require that children need to leave education and provide a substitute for household labor or income loss. Okay, while in case of child labor, the effect on child labor is theoretically ambiguous. Children may need to increase the labor supply to substitute the income loss, or may need to decrease the labor supply to take care of the ill parent. Okay, so with this background, the objective of our paper is, and here in this paper, we measure the incidence and intensity of catastrophic health expenditure. We estimate the impoverishment effect of out-of-pocket health expenditure. Further, we explore the intergenerational effect of parental health shock on child education, okay, and the child labor supply. And finally, we investigate whether there are differential impact from the father health shock as compared to mother health shock, and across the gender and across the different age groups of the children. Okay, so our studies embodied many distinctive features. For example, we used multiple measures of health shock, self-reported mobility, long-term mobility, days unable to do their usual work, days hospitalized, and difficulties in ADLS. Okay. Similarly, rather than just school enrollment, we include different indicators for child education also. Okay. While most of the previous studies, those who are available, okay, mainly focus on the impact of child education only, but we also examine the impact on the child labor so that we can identify the channels through which parental health shock can affect the child education. Okay. Further, we are using panel data set fixed effect model. Okay, as in the objective, I said we estimate the parental health shock across the gender and different age group of the children, and separately for mother and father health shock. Okay, for this study, we are using the IHDS data, Indian Human Development Survey data, the panel data, 2-round panel data, which is a national representative panel data set. Okay, and for the child, for the effect on the children education, so based on latest research, we include the children aged between 6 to 23 years who are living with their both parents only, okay, in our sample. So we are excluding the children living with one parent or without parent. And with respect to the methodology, we are using the standard incidence and intensity approach to capture or calculate the catastrophic health expenditure. Similarly, we are using poverty head count and poverty gap to estimate the impoverishment effect of catastrophic health expenditure. Okay, and then finally, to calculate the parental health effect on the children education and labor supply, we are using fixed effect model, which allow controlling for unobserved time invariant characteristic of the children as well as the parent. Okay, so I'm just going to briefly explain the results, what we have found in this paper. So this is the table indicating the incidence and intensity of catastrophic health expenditure, where we can see that a significant number of households incur catastrophic health expenditure at any specific threshold. And we also observe that as share of the non-food expenditure, more household incur catastrophic health expenditure as compared to a share of total household expenditure. Okay, we also find that more number of household incur catastrophic health expenditure at the same threshold in the year 2011-12 as compared to 2004-5. So it is possible due to increasing the health cost and several other costs related to health expenditure. Similarly, for the impoverishment, we find that with respect to household per capita consumption, in 2004-5, 27% household belongs to the poverty or living below the poverty line, and 20% in the year 2011-12. Okay, and when we account for
Nadeem, you have a minute left.
Okay, when we account of catastrophic health expenditure, then it is increased to 33% and 27%. It means that around 6 to 7% household push into the poverty due to out-of-pocket health expenditure. Okay, similarly, in this case, we find that the overall, our finding confirmed that the parental, especially the father health shock, has considerably adverse effect on the children education. Okay, and it will increase the children's likelihood to enter in the labor force. Okay, and the effect is more stronger when both parents affected from the health shock, and we find that boys are more affected by the parental health shock as compared to girl. It is possible because of boys need to substitute or to provide the substitute for the labor loss. Okay, so because I have only 1 minute, so I'm just going to the conclusion. So these are the conclusions that I have explained based on the results. So finally, we can argue that our study provides the policy implication that health shock schemes are required to not only provide or considering the affordable health care, but also need to provide income security and safeguard to protect the household from the catastrophic health expenditure, especially the children who forced to.
Nadeem, I'm sorry, but you're out of time. So
Okay,
you'll have
just
to.
last sentence, ma'am. They forced to
No, I'm
leave the
sorry. I'm
education.
sorry. We have to maintain time. I'm sorry.
Okay, okay. So thank you
please,
so much. I
thank you.
welcome to take your question.
And yeah, we'll take questions at the end.
Okay.
Our next presenter is Elena. Elena, could you please share your
No
screen
problem. Yep.
and also introduce yourself?
Yes. I am Elena Patel. I'm an assistant professor at the University of Utah in the finance department. This is work that is joint with Atai Luri and Shanti Ramnath, both of whom are at federal agencies, which means I need to tell you that these are our views. They are not the views of the Treasury Department or the Federal Reserve Bank of Chicago. This paper is called Inducing Labor, the Impact of Healthcare Access on the Child Penalty. The title's been updated a couple of times, so you might see a different title in the program. We're really looking at how access to health insurance impacts postnatal labor supply for parents. The reason why we look at this in the United States is because in the US, there's a really strong connection between employment decisions and the provision and access to health insurance. And so we know that the cost and quality of health insurance options are linked to employment decisions. What we're going to look at is the Affordable Care Act, which was fully enacted in 2014 and fundamentally changed the market for health insurance in the United States. And we're going to focus sort of on two dimensions. One, the ACA increased access to insurance for all Americans, regardless of whether or not you're employed. And for this reason, it altered fundamentally the relationship with employment. And so what we're going to do is focus on a specific health event, childbirth, and look at how the implementation of the ACA influences labor supply decisions in the context of this observable health event. The analysis that we do relies on US administrative tax data. And so what we do is we draw a 10% sample of first-time mothers that gave birth before and after the ACA, so 2013 and 2015. We're going to look at mothers aged 26 to 44. This is in part because some provisions of the ACA rolled in a little bit sooner. In 2011, up to 26-year-olds could get insurance through their parents. And so we focus on those that were specifically impacted by the ACA in 2014 when everything came online. So this 10% sample is going to be about 150,000 births. For these mothers, we match them to fathers to the extent that we can. Not all mothers report a father on birth certificates. And so we match them to about 130,000 fathers. And then we use the administrative tax data to create a panel of labor supply decisions. So this includes annual earnings and employment information for 3 years before birth up through 4 years after birth. So the data is going to go from 2010 to 2018. And what we grab are wage earnings, which is going to tell us if you are a wage employee, which again is a specific kind of employment in the United States, the most common kind of employment. We also look at self-employment and self-employment income. And what we're going to do is compare mothers and fathers' labor market outcomes for these births that occur before and after the ACA using a triple difference empirical framework. Just to get a picture sense, triple differences are the easiest to understand if you can see what's happening in the data. And so in general, what we find is a large persistent gap in post-birth labor supply. So this is for all births. It doesn't matter when they happen. On the left, it's the propensity to be employed. So that is the extensive margin of labor supply. On the right, we have wage earnings. So there are zeros here. This is going to mix up both the decision to work and how much to work. The triangle lines are the dads. The circle lines are the moms, and the vertical axis is when the birth occurs. And what you see is that in the United States, like other countries that's been well documented, there is a sharp divergence in labor supply that occurs at birth. So mothers are much less likely to be working, and they start to earn much less as soon as the birth occurs. So this is called the child penalty. There's sort of a new literature looking at this child penalty and what the mechanisms are that could be causing this. What we know in the United States is that the ACA expanded coverage, and it expanded coverage in the months surrounding birth, both through public insurance mechanisms like Medicaid, but also through private insurance. And so what you see here in the gray lines are pre-ACA coverage rates. On the bottom are Medicaid programs, CHIP, sort of the federal programs. The top are the privately insured. And post the ACA in the black lines, you can see that for privately insured parents, for example, they're between 2 and 3 percentage points more likely to be covered in the months surrounding birth, which is what we see in this graph. For the Medicaid population, the low income population, they tend to get expanded coverage post ACA during the postnatal period. Mothers in the United States, low income mothers before the ACA already had expanded access to public health insurance programs at the time of pregnancy. And so you sort of see the private lines diverge immediately post and pre. On the bottom, what we see is that during the prenatal period, there really isn't much difference in access that comes postnatally. What we find in this triple difference, the triple difference is going to compare the relative labor supply and relative earnings of mothers and fathers for those births that take place before the ACA compared to after. And so that's what you see in these lines. The black lines here are the pre-ACA, the gray lines are the post-ACA, and this is showing you relative employment, where it goes below zero because mothers are less likely to be employed and they earn less than fathers. Again, the vertical line in the middle is when you give birth. And what we see is that the gray line on the left for wage employment is above the black line, which means that the gap is shrinking. Mothers are more likely to be working after the ACA as compared to before the ACA. And that's what we're going to measure with the triple difference. But this is sort of a visualization of what the triple difference is measuring: the relative labor supply and the relative earnings for mothers compared to fathers. And so what we have here are triple difference, sort of the event study, dynamic difference and difference. And what you see in the -3 is there's no statistical difference in earnings, and the magnitude is really not very meaningful. Mothers and fathers before they give birth, before and after the ACA, are similarly employed. -2 is the left out period. Pregnancy is when the access to insurance starts to matter. And what you see is that for post-ACA births, mothers are more likely to be employed as compared to the pre-ACA births. And so it ticks up to about 1.4 percentage points, sort of, again, sharply at birth, and then it sort of hovers there. And so that means that mothers are 1.4 percentage points more likely to be working after the ACA as compared to before the ACA, always relative to what fathers are doing. We cut this in a lot of ways, so trying to get at what the mechanisms could possibly be. So on the left, you can see our point estimate, the 1.4 percentage points. On the right, we look at by sort of household structure, joint and non-joint filers. That's alike, married and single, but a little bit different. And you can see that this impact is persistent across household structure. We cut it by the income distribution. FPL here means the federal poverty level. So a lot of means tested programs are relative to a federal benchmark for poverty. And so we look from low to high income mothers. Again, it's a robust result. These mothers are all robustly more likely to be working after the ACA. We cut it by age. There really is no heterogeneity. And so sort of it seems that for the demographics that we have in the tax data, this is a robust result, that mothers are more likely to be working after the ACA if they give birth as compared to before ACA births. The other thing we look at is just if there is consistency with the ACA mechanisms. And so the ACA has some variation within the US states for those that chose to expand access to low-income programs. Those are called expansion states compared to non-expansion states. Again, robust. We look at places that had low employer-sponsored insurance compared to high employer-sponsored insurance. The ACA is going to be more impactful in places where people had lower access to ESI. Again, we sort of see suggestive evidence of trends, but everything is robust. This result is robust by mothers' characteristics, by the ACA expansion. And so to quickly conclude here, what we find, yep, Priya, okay, yep.
Sorry, you're almost running out of time.
Yep.
Yeah.
So we find that access to health insurance plays a role in driving this post-birth gendered labor supply gap. And we think it's through the mechanisms that tie employment to access to insurance. And what we look at specifically is at a health event, and surrounding a health event, we find that with increased access, you have increased employment. And so in particular, mothers are 1.4 percentage points more likely to work. The result is robust. And the child penalty literature suggests that if you can shrink this gap, there is a mechanism by which you might be able to shrink the broader gender wage gap. Thanks.
Thank you. That was right on time. For our participants who joined later, I just want to mention that you are welcome to write your questions and comments in the chat box below, and we will open the floor for questions right at the end of all presentations. Our next presenter is Liana.
Great. Are you able to see my screen?
Yes.
Great. I'm Liana Rosenkrantz-Waske. I'm currently a PhD candidate at the London School of Economics in the program in Health Policy and Health Economics. And I also am a research fellow at the Harvard T.H. Chan School of Public Health, working with Professor Winnie Yip on the Gates India project. And today I'll be presenting some summary prevalence results from a project I've been doing as part of my dissertation to estimate patient-centeredness in modern family planning care. This research is unfunded, but does extend on output from Family Planning 2020, as well as a broader project conducted with the US National Academy of Medicine to quantify the burden of poor quality care in low and middle income countries. And I would like to thank my mentors, Irene Papa-Nicholas, Claire Wenham, Winnie Yip, and Dr. Ashish Jha. So in 2020, multilaterals, donors, and civil society gathered at the London Summit on Family Planning, and this summit resulted in unprecedented global political commitments and resources to enable 1 million more women and girls to use contraceptives by 2020. We have now passed 2020. And the estimate that resulted from that work was that 53 million women newly initiated the use of modern contraceptive in those target countries. Sorry. Throughout, there's been a stated commitment to women's rights and person-centeredness. For example, the Family Planning 2020 Statement of Principles reads as follows, that access and uptake of modern family planning services are widely understood to enable women's autonomy, but actual autonomy within the uptake of modern family planning is much less well studied. So looking at the modern family planning goals themselves, we examine agency and autonomy, availability and accessibility, as well as informed choice amongst those 53 million women. And
I'm sorry to interrupt you, but have you changed your slide? Because I'm still seeing the cover.
Yes. Oh, I'm so sorry.
Is anyone else able to see anything besides the top slide?
Are you able to see the research questions?
Yes, we can see research questions now. Thank you.
Sorry about that. So the 3 research questions are the following. Of the 53 million women who gained access to modern family planning from 2012 to 2020, to what extent was the decision to utilize a given method autonomous, i.e. a woman's own choice? What methods were available to women at the point of purchase and how concentrated were those options? And then finally, what share were told about alternate modern family planning methods, side effects of their chosen method, or what to do if side effects did occur? And so this is largely an exercise in aggregating data across a series of different data sets. So looking at mix, RHS, DHS, PMA, etc. So in total, this effort includes an examination of data collected via surveys from 918,000 women across 68 different countries between 2012 and July 2019. In line with the DHS selection criteria, this is largely focused on women aged 15 to 49 who initiated within that study period. And then just to review what modern family planning means, both reversible and permanent long-term options, as well as injectables, pill, patch, ring, diaphragm, and regular condom use. I'll just skip through this because I know we don't have a ton of time, but just to review the summary results from question 1. So aggregating results across those survey tools, we find that approximately 90.8% of women, were able to make an autonomous decision either by themselves or in joint partnership with their partners to use the modern family planning method that they are currently on. However, that differs dramatically by wealth quintile. And if people are familiar with wealth quintile, it's an aggregate measure of wealth that looks at physical resources and other indicators. And we find a statistically significant difference between the wealth quintile, and that varies dramatically by country. And I apologize, these slides are a little silly, but you can see each country represented on the x-axis, and then the discrepancy between wealth quintile in the bars. And so what methods, though, are actually accessible or available to women at the point of purchase? And for this, we find the percent of secondary care facilities with we have fewer countries for this measure with comparable data, but find that on average, 75.7% of primary care facilities had at least 3 methods available during routine spot checks, or alternatively, almost 25% did not have 3 available. And the next indicator is 5 methods in secondary care facilities. And we find a mean of 73%, but with much wider variability in the secondary care facilities than primary care. And then we also look at distribution of method type amongst family planning users. So not just available at the point of purchase, but what methods are actually being used amongst the recently covered. But here we can see that the share of the population is using what method. And there's high use of injection and pills in most countries, which you can see with the blue and green. But what we're most interested in here is distribution and variety of options. And while there might be some variation in preferences between different populations, a high concentration of methods generally is considered a complementary indicator to method availability. And this is particularly relevant if spot checks, which is the approach used to assess methods available at the point of purchase, are anticipated by facilities. So the last thing that we just looked at. And so for here, if we do a HHI, we see the country with the most even distribution of methods is Bolivia, whereas the most concentrated by a significant amount is North Korea. And then the third and final question for this is, when women initiated their current family planning method, were they told about alternate family planning methods, side effects of their chosen method, or what to do if side effects did occur? And this was also a core measure for FP 2020, so people might be familiar with this. And so what we find that on average, only 42.2% of women responded yes to all 3 questions across the study population. And however, for non-permanent methods, this was 47%. And then amongst permanent family planning users, so these are women who are sterilized, it was only 33%. And so just to reiterate, that's only 33% of women were told about all 3 of the following: alternate family planning methods, side effects of their chosen method, or what to do if side effects did occur. And there are a number of clinically relevant side effects to tubal ligation and other common forms of sterilization. So just to reflect quickly on this work, apologize, these are very preliminary descriptive results. And there is, I'm sorry, what?
You have a minute left.
Okay, great. I'll just go down to the summary of findings. So we find on average that 10.3% of women reported not having made the decision to use their current modern family planning. And on average, 24.3% of primary care facilities had less than 3 methods available. And perhaps the most concerning was regarding informed choice. So on average, 39.7% of women were not provided with information required for truly informed consent. And given the large share of women who are utilizing permanent family planning methods, this is quite concerning. And this work is being used to inform a measure of informed consent adjusted family planning. And so this is sort of a preliminary descriptive results that are informing that measurement exercise.
Thank you. That's really interesting. We have our last speaker for the day, Emmanuel. Emmanuel, can you please share your screen?
Can you see my screen?
Yes.
Not my notes. Okay, great. Okay, I'll get started. Okay, so good afternoon, good morning, good evening. My name is Emmanuelle Arpin. I'm a PhD candidate in health economics at the University of Toronto in Toronto, Canada. I'm so pleased to be here today to share some preliminary results from a study that is part of my dissertation, which examines the long-term effects of health conditions in childhood in the Canadian context. And I would like to acknowledge my co-authors who are listed here, who are also my committee members, Claire de Oliveira, Arjumand Siddiqui, and Audrey Laporte. So there's a growth in theoretical and empirical literature to suggest that health inequalities that we observe in childhood may explain health and socioeconomic inequalities that we also observe in young adulthood. So on the empirical literature side, there is quite a bit of robust literature to support the finding that children who suffer an illness fare worse on both short and long-term outcomes. And I've listed a few examples here on this slide. There's also theoretical backing, and one framework that's quite useful to understand the relationship between these two periods is the Kuhn and Heckman framework, which suggests that child development is a dynamic process over the life course where skills build on each other over time. There's a little bit more limited evidence in the Canadian context. One is due to data limitations, and I'll talk a little bit more about that later. And there's also few studies in this context that have examined chronic conditions. And chronic conditions are quite interesting because we're seeing a growth in them, especially as they relate to mental health, which is what's indicated on the graph or the figure on the right there. But there is, a good reason to examine chronic conditions, as it does represent a sudden shock to a child's regular skill building activities, and also represents significant time away from regular skill building activities, which distinguishes it very much from an acute condition such as a broken arm or something like that. Something else that's not quite well understood in this literature generally too is the pathway effects. So this is to understand and interpret the relationship or the mechanisms between these two periods. And borrowing from the social epidemiological literature and also from economics, we can distinguish a direct path and also an indirect path. So with this background in mind, this study had three broad objectives. One, it was to examine the long-term effects of chronic conditions in childhood as they relate to physical and mental health on health and socioeconomic outcomes in young adulthood in the Canadian context. We also wanted to examine any heterogeneous effects of these health conditions with other factors such as parental SES indicators to see, for example, if there is a type of cushioning effect, which is something that has been established in the previous literature. And we also wanted to examine any pathways. Now, for brevity, I'm just focusing on the first objective, but I'm happy to discuss any further results in the discussion period or offline as well. So one thing that I find really exciting and quite special about this study is the data. So I mentioned briefly before that data is definitely a challenge when it comes to understanding the long-term effects of things that happen in childhood on later outcomes. And usually we do rely on longitudinal data. And Canada has only one longitudinal nationally representative survey of children and youth. And this survey started in the early 90s and ended in 2008. So it's now terminated. Statistics Canada, who ran this longitudinal survey, started to make some efforts in order to make these types of data that are relatively older a little bit more relevant by linking them to administrative data. And this longitudinal survey was linked to tax data. And where it becomes really interesting for questions about long-term effects of health conditions in childhood is that not only did the linkage include new variables to the existing waves of the survey in question, but it also extended the life of the period where we could follow these children. So to give you an illustration, where the NLSCY, the longitudinal survey, ended in 2008, where the oldest child was 25, with the tax linkage, we can now see them up to 2015, up to the age of 33. So we can get a good sense of what's going on in young adulthood. So for the measures, our main predictors are the childhood chronic conditions, and the NLSCY, the childhood survey, is very rich with indicators of diagnosed physical and mental health conditions. So we look at it at a gamut of these types of conditions, and we also have a question that relates to a limiting condition. And this is really interesting because it relates directly to the Kuhn and Heckman framework. For the outcomes in young adulthood, this is where we use the administrative tax data. And here what's been really interesting as an exercise, a data exercise, is to use the monetary measures that are included in the tax data, such as income, after-tax market income, but we can also create or derive certain indicators of health and education, for example, by using measures of different claims that are made, such as workers' compensation claims and tuition credits. So you can create indicators of years of education or an indicator of poor health. So the approach was quite straightforward. We use OLS at LPM depending on the outcome. And also to address any form of unobserved heterogeneity, we applied a family fixed effects approach. So the family fixed effects approach is very useful to address those technical issues around unobserved heterogeneity, but more substantively, it also means that we're looking at differences between siblings within families. So our sample of siblings is quite large. We have about 6,000 siblings from our sample, our full sample. And we also confirmed that we do have sufficient variation on the outcomes of interest within families, which is essential for the fixed effects approach. So I'm giving a table here that kind of summarizes all the results that we have so far. And I just want to walk you through some key takeaways. So what we do see here is that conditions that affect physical and mental health do carry long-term effects on later outcomes. We can see, however, that for physical health conditions, it's more limited. It only affects health and social assistance take-up in young adulthood, whereas for mental health conditions, it across the board affects all of our long-term outcomes of interest. I also want to draw your attention to asthma. We see here that there are no significant effects, and this actually builds on the previous literature, which examines the long-term effects of asthma that finds null results. And the final thing that I want to show here on this table is that the effects of mental health conditions do persist within families. So we can see that in the family fixed effects column. So just some key takeaways. So we do see in this study that health conditions in childhood do impact health and socioeconomic outcomes in young adulthood. And we also see a significant effect of mental health conditions. And there are many hypotheses to unpack why this may be if we compare them to physical health conditions. And I'd be happy to unpack those a little bit more in the discussion. Also, we see that there's significant within family effects. And this is quite interesting because we can see that there's these differences between siblings, even for these long-term outcomes. So this suggests that parents may be investing differently between siblings, or all siblings may be impacted by a sibling's health. Not shown here, we also looked at some heterogeneous effects, and we find
You've just under a minute left.
Okay, thank you. So we do see some heterogeneous effects by birth weight and also by age, which suggests some life cycle effects. So this could suggest that health conditions in childhood are starting to constrain skill acquisition and setting children off on certain educational or income trajectories. We also start to see some evidence of an indirect pathway through education, which actually contrasts some results from the US that have also examined these types of pathways. And just to close, when we think about some policy implications of this work can suggest or encourage some policy investments in childhood in order to mitigate the occurrence of health conditions in childhood, and also to ensure timely and adequate access to care, such as education and health services, in order to limit any considerable long-term impacts of these health conditions. And with that, I close, and thank you very much for your attention.
Thank you. Those were really interesting, and I say some very rigorous presentations. Even though Liana wants to call hers preliminary, I thought there was a lot of work involved. Thank you very much for that interesting presentation. I'll now open the floor to questions. If anybody would like to ask a question, you're welcome to type or raise your hands. And we have around, just around, I think about little over 20 minutes for discussion. So please feel free to raise your hand or ask questions. Yes, Scott.
Yes.
Please briefly introduce yourself also.
Can you hear me?
Yes.
Okay. Emmanuel, could you please clarify about the mental health conditions? I noticed your abstract referred to cognitive issues, since not clear, is the economics literature distinguishes between cognitive ability and behavioral attributes.
Mhm.
Could you
Yes.
speculate as to how to interpret these findings on the mental health?
Yeah, so I have to say in the NLSCY, with the survey, I've been quite lucky to have just a whole array of different types of broadly mental health conditions. So we do have things that are diagnosed. We also have developmental conditions such as ADHD, and cognitive measures would be related to kind of indicators that are included in the, like, scores that are indicated. And I think too, if you're, the cognitive indicators too can also relate more directly to the Kuhn and Heckman framework as well, and skill building and cognitive and non-cognitive skill building. And I have to say, in the results that I did show, they do relate more to the mental health and developmental diagnosed conditions. So these aren't the results that directly relate to those scores that would maybe relate more directly to cognitive skills as defined in the Kuhn and Heckman framework. I'm not sure if that is sufficient answer.
Like ADHD is not a matter of cognitive skills.
No.
It's more a matter of the behavioral.
Yes. Yes, and what's presented here is more related to the behavioral issues. So the results that I presented here are more mental health, such as anxiety, and behavioral such as ADHD, not so much the cognitive results here. But great catch for seeing that in the abstract that was submitted earlier. And if you are interested, I can share those types of results too. Thank you for your question.
Would someone else like to ask a question? The four speakers.
I actually had a question for Elena. I'm wondering about the difference. Well, on the one hand, if this may matter in the child penalty literature, and then also more practically, if you looked at it to see if you can see first birth, the difference between a first birth and a second or third birth, and what may be the difference in these impacts.
That's a really good question. So we have limited the analysis to first births. I don't know if I said that, but first births are cleaner for a lot of reasons. We think sort of parents make sticky decisions about how they're going to parent their kids. And when the second and third birth comes around, they sort of are doing the thing they did with the first birth. And so that analysis is limited to first births. We haven't done an all births analysis of it because we worry about contamination and sort of the triple difference sense and between the treatment and the control group in terms of when you're sort of treated by the ACA with your prenatal experience. And again, stickiness of the health impacts of a bad first prenatal experience that might have come before the ACA as compared to second and third births that happen after the ACA. In other work that I have, I've done sort of paid family leave work using tax data. And again, we've kind of limited that to first birth analyses, but we've done an all births analyses of the impacts of paid leave in California, for example, on labor supply and mothers and women's labor supply decisions. And that's one where we see really prominent effects for first births, and then they're sort of gone for subsequent births that happen after paid family leave as compared to before. And again, my instinct is because I think parenting decisions roughly are made with the first birth and then they sort of continue on thereafter. Not that people don't make changes, but they kind of keep doing the thing that they were doing before. And so we will do an all births analysis in this particular context. My suspicion is that the impact will be much more muted. We just haven't pulled the data for that yet.
Thanks.
Thank you. Someone else would like to ask a question? Liana, actually, I have a question for you. I know you said your work is preliminary, but while we're waiting for others to ask, I'll just take my chance. So it's very interesting how you combined all these very large surveys, 68 of them, and you looked at the choice, whether the women are exercising the choice to use modern contraception or not. And I'm just wondering if in your analysis, was there any focus or during your work, have you looked at what factors can actually affect that choice? So I know that the questions are, whether you're allowed to use or not, or whether you're doing it jointly with the husband or someone else in the family. But from a policy point of view, what are the factors that could possibly help women or enable them to make this choice? And the second is, I'm assuming that your sample only looked at the users, right? So were there also women among the non-users who really didn't have a choice. I mean, they were non-users because they were deprived of that, they didn't have the agency or the autonomy to make that decision.
Right. No, I think that those are hugely important questions. With the international data, it's very challenging to look at things like patient characteristics, etc. So one of my other papers is a much deeper dive at the national level into sort of drivers of autonomous choice or non-autonomous choice. I mean, I think the thing which is quite consistent with prior literature is education and also rurality are two of the most common things, which is why I also look at accessibility. So you could theoretically have 3 or more options available in the facilities that are closest to women. But if that facility is 20 miles away, it sort of, and then that's why we also look at the IHEA is what are women actually using? So if the spot check stuff is interesting to get a rough sense of what's accessible in the facilities, but a lot of facilities know when those are about to happen or have a rough sense, so may stock up prior to, and that's a broader issue across countries, and I know folks who work more with the DHS survey tools, sort of anticipatory performance enhancement, things like that. But I think it's complicated, and I would love to chat with you more about this because I'm actually just diving into the patient level data right now and actually looking at those drivers. And so I can give you a high level response, but I'm asking those questions at the moment.
Thank you. Are there any more questions for our speakers today? So I still have a bunch of questions and no one else is asking. So Nadeem, I know I shouldn't be asking you, but I am going to ask. So in your analysis, and a brief answer would help here, in your analysis, you're looking at the impact on labor supply, child labor supply, and whether, having a health shock. So for instance, we're in the middle of a pandemic, and having a health shock like a pandemic, it's definitely disrupted education for children. It's just resulted in loss of livelihoods across nations. But what I'm wondering is, in the kind of data that you've picked up, how does having a larger extended family system or having multiple siblings, you're looking at the IHDS, and it's possible that, family size and that sort of a data set is very large. So how does the presence of, say, grandparents who might be entitled to pensions, older siblings who might hold some kind of a job, does that really help sort of lessen or cushion the impact of a health shock on these children's education and labor supply?
Okay, this is a very nice question. Okay, so in effect of like the different family size, like number of household members, old member in the family, number of siblings, and number of working members also, how many number of working members in the household. So basically for this estimation, I have used the data of children level data, children, those who are below the age of 6 years to 23 years. And in addition to considering the effect of these family background or family characteristics, I have controlled for all the type of household characteristics, including like if there is an old member available in the family, if this effect is affected or not, and similarly if the number of siblings, and especially if the number of workers in the family. Okay, if there are more number of workers in the family, so that it's possible that other family member can substitute the labor supply loss. Okay, by increasing their labor supply. So it's possible that children may not need to increase or leave their education. Okay, so we find the several effect that if a number of people are the family size, how the family size can affect how the presence of old and children in the family, and especially the number of working age members in the family.
Thank you. Is there anyone else who would like to ask a question? All right, then I'll go ahead again. I still have a lot of questions. I don't think I'll be able to complete all my questions, so I'll probably correspond with all of you, later on. Emmanuel, I thought that was really interesting to look at, the impact of long-term and short-term child health outcomes and its impact on cognitive development and test scores. I was just curious because you showed that table on physical, when you showed your results, you had physical health and you had mental health, and mental health across the board seemed to have a negative impact. I was just curious as to how you defined physical health. There was something called limiting condition. And also, how is it that asthma is not considered to be a part of physical health and you're treating that separately? So just a two-part question: how are you defining physical health, and what are the other kinds of controls that you might have included in those regressions? Because that was a very surprising set of results. I mean, a priori, I expected something else.
Sure, thank you for your question. So the NLSCY, the main childhood survey, was very rich in having information about diagnosed conditions, health conditions, chronic conditions, many things like epilepsy, ADHD, cerebral palsy, diabetes. So we have a lot of this information. So I ran everything looking at those individual conditions, but also created these aggregate measures of at least one type of physical condition, at least one type of mental health or developmental condition. So for the physical conditions, we do have things like diabetes. We do have things like respiratory illnesses, bronchitis, allergies, and things like that. And asthma is also included. But since asthma represents the top physical chronic condition in childhood in Canada, and hyperactivity ADHD represents the top mental or developmental condition in Canada, I ran those separately, and since the results were quite interesting to also contrast as a standalone condition, they were included there. But I do get that question a lot, and actually in this literature, they do come up with these types of aggregate measures that include many conditions, but I think it's definitely worth looking at every single condition as well. And then, finding null results for asthma, that's actually been found in this literature as well. I think of someone, Fletcher, he's produced quite a bit of work on asthma, and for the most part, the long-term conditions or the long-term effects are null, really, and that could be because asthma is diagnosed quite a bit in childhood, but it's not one that actually lasts a very long time into adolescence. And it's also something that's quite manageable. At least here in Canada, things that are considered physical conditions are part of the basket of things that are covered in the basket of services that are universally covered. So it's quote unquote easy to go get a puffer, a prescription for those types of things. They're more manageable and observable, whereas mental health conditions actually fall, and the treatment fall outside of the basket of things that are under the universal healthcare program. So there could be issues around cost, about proper treatment that are juxtaposing or compounding the effect of mental health conditions compared to physical health conditions. So that could be also one of the mechanisms to explain why. But that might be just a bit more specific to the Canadian context too, about what is in and what is out of the healthcare system, the publicly.
Thank you. Elena, I'll just take my chance before anyone else raises their hand. So I'm not familiar with the ACA, but I read up on it a bit. And I was just curious to know, one, does it have an age limit? I mean, when you have this health insurance coming in, is there an age limit below which you cannot provide it, which is why you're looking at 26 to, 26 and above? And is it that does the impact on labor supply, does it vary by the type of occupation that a woman chooses, like say it's a full-time versus a part-time, or an office job, or something that you can do from home? Does that make, I mean, have you difference in the kind of labor supply changes that we see there?
Yeah, thanks for both questions. So one, the 26 to 44 restriction is new. So if anybody kind of looked at the previous version of the paper, I'm glad to get a chance to just explain what we've done here. The ACA was passed in 2010, and it sort of fully came online in 2014, but parts of it trickled between 2010 and 2014. And so what happened in 2011 is the young adult expansion, as we call it in the US. And so people below the age of 26 starting in 2011, could choose to stay as dependents on their parents' healthcare plans. And they used to get kicked off at 18 or sort of when they exit college. And so there's this gap for young adults, roughly between 21 and 25, where they were young and feeling invincible. So they didn't take up insurance, also didn't usually have access to it at their employer, and they weren't covered. And so once the ACA in 2011 allows for them to stay on their parents' plan, there's a big expansion for young adults. And so that's why we kind of carve those younger mothers out. One, because we know younger mothers, 21, 22, and even younger, are sort of fundamentally different than older mothers. Also, younger mothers don't really have pre-birth earnings histories that are meaningful in the US. So we see them in the tax data. If you give birth at 21 and we're trying to go 3 years back, we're sort of looking at 18-year-olds and like comparing an 18-year-old's earnings to a 25-year-old's earnings, just in the life cycle, is fundamentally different. And so there's a couple of reasons why we focused on the 26 to 44. One, in 2014, that's really when they gain access to the provisions of the ACA. And two, it gives us a meaningful sort of pre-birth comparison for mothers and fathers that's not conflating sort of part-time earnings that would show up while you're in college on your tax returns, but aren't really reflective of sort of full life cycle labor supply decisions. So those are kind of the reasons why we moved to the 26 to 44. It's actually an identification reason. The comparability of mothers and fathers in the pre-period is much more reasonable for those mothers and fathers when the mom gives birth sort of after age 26. So that was a long answer, but I'm glad to get the chance to give you the answer because the original version of the paper doesn't really have that explanation in there. Your second question is sort of whether I would expect to see heterogeneity by occupation of the mother. I absolutely would. The unfortunate thing is for the tax data, that's a pretty hard thing to see. So in the US, the tax data is not linked to things like the census. And so somebody can choose to self-report their occupation on their tax return, but that's very non-random in terms of who chooses to self-report it and then how they code their occupation. And so for that reason, the tax data unfortunately really can't speak to differences in occupation. The child penalty literature, so the original paper by Heinrich Kleven and co-authors using Danish data, does look at occupational choices of mothers as one of the mechanisms that drives a child penalty. And they do find suggestive evidence that the women whose labor supply and sort of intensive margin choices like hours, number of hours worked, they are switching or they are in and selected into these family-friendly careers. And so that can drive some of the child penalty because they're sort of picking different tracks in order to be able to provide childcare. So there's pretty good empirical evidence that that's some of the mechanism for the child penalty itself. The US data, unfortunately, just doesn't lend itself to that kind of analysis because of the way it's decoupled from things like census surveys.
Thank you. Thank you so much. We just have a couple of minutes left for the session. So is there anybody else who would like to ask a question? Please go ahead. Or comment or suggestion. Okay, I think then we'll just wrap it up in time, giving time to the participants before our next, which is, I think, a centerpiece session on the economics of vaccine markets. Should be interesting. Thank you very much, Elena, Liana, Nadeem, and Emmanuel, for your presentations. It was very interesting for me, at least. I learned a lot, and I hope to be in touch with you again regarding your work soon. Thank you, and thank you to all our participants for being a great audience. Thank you.